Welcome! This training video provides a comprehensive overview of the BrightMEM anterior keratoplasty procedure. The video includes tips, techniques, and best practices to help you increase your confidence in mastering this procedure. We hope that you find it informative and useful. Thank you for watching. Please note that the surgical video does not represent one complete case, but is compiled from multiple cases to showcase best practices. To prepare the patient's cornea, a superficial keratectomy is performed. This step may be relatively short or prolonged if bleeding is encountered. Pressure from cellulose spears or a pledged phenylephrine solution can help control bleeding. The surface must be left dry. The diameter of the bare stromal surface will vary with the clinical scenario. It is important to leave a 0.5 mm gap between the allograft edges and the residual epithelium. For example, using an 8 mm allograft requires a 9 mm superficial keratectomy. Before trephination, it is important to examine the corneal button through the microscope because the pre-peeled allograft may be wrinkled or folded. Small wrinkles or folds of an edge over the allograft can be easily straightened using a blunt tying forceps or similar instrument. It may be easier to maneuver the allograft after wicking off fluid that sits on top of the graft and in the trephine well. Some folds result in an edge beneath the allograft. These can be straightened by carefully dragging the graft 90 degrees away from the fold, allowing the portion underneath to open and unfold. The maneuvers are different. Overfolds are corrected by flipping the folded edge outward, while underfolds are corrected by dragging the tissue centrally, away from the fold. While the surgeon should be delicate, the allograft is relatively resistant to tearing. Tilting the tissue allows gravity to assist a few drops of BSS in flattening the allograft, as does wicking away fluid from the allograft edge. Remove the tissue from the tissue chamber by grasping the corneoscleral rim with toothed forceps. Avoid touching the clear cornea with toothed instruments. We recommend the use of a vacuum trephine to hold the button securely during trephination. The trephine blade may be marked with a marking pen to improve graft visualization. The S stamp should be within the trephined area. We recommend a maximum trephine size of 8.5 mm. Before placing the trephined button on the patient's eye, ensure the stromal bed is completely dry to ensure good adhesion of the membrane. The allograft will slide if fluid is present. Care should be taken that the button is centered on the area of epithelial debridement and does not overlap with any intact epithelium. Once the button is centralized, do not move it, as this will result in tissue wrinkles or folds. Over 2 minutes, wick out any residual fluid using Wexel spears without moving the tissue. At this point, the allograft should be moderately adherent to the patient's stroma, and the surgeon can remove the donor stromal cap. This can be accomplished several ways, including obliquely lifting the stromal tissue with a .12 forceps, or by nudging the stromal tissue to slide off the allograft beneath using a blunt tying forceps. Once the allograft edge is visible, a .12 forceps is used to remove the stromal tissue. Straightening the allograft can be accomplished with a series of maneuvers. Always start by adding 1 to 2 drops of BSS solution, as the weight of the drops will help flatten small wrinkles. The surgeon can use the edge of the BSS cannula or a muscle hook to squeegee the allograft, pressing down to force out fluid from beneath the allograft. A blunt tying forceps can be used to slightly tug the tissue, moving 90 degrees away from the evident folds. If these techniques are not sufficient, the surgeon can refloat the allograft by gently irrigating beneath the tissue, much as refloating a Lasik flap. Then follow the same series of maneuvers until no wrinkles or folds are observed. A Lasik flap roller can be used to gently press down and force interface fluid out from beneath the allograft. The final step is the application of tissue glue to aid in allograft edge adherence. It is not necessary to place glue centrally, just at the 3 and 9 o'clock positions. After placing 1 small drop of component 1 at 3 and 9 o'clock, use a 25 gauge cannula to spread the component over 3 to 4 clock hours at each location. Then add component number 2 centrally, and because it is thinner, it will spread and begin polymerization. After 45 seconds, the surgeon can place a flat-fitting contact lens. Ensure there are no air bubbles beneath the contact lens. If excessive glue is observed beyond the contact lens edge, do not pull it, but cut off excess with a Westcott scissor. The ideal patient for BrightMEM anterior keratoplasty has non-healing corneal defects, post-herpetic, post-surgical, atopic, etc. Patients with 25 to 75% limbal stem cell deficiency, with or without an epithelial defect, are also very appropriate. Avoid choosing severe ocular surface problems, particularly cases with active inflammation, stromal edema, uncontrolled IOP, or insufficient fornix depth to allow bandage contact lens fitting. We hope you have found this video about BMAC informative. Thank you for watching. You can find more information and training resources on our website at www.brightstartx.com/surgeon training.